Hello, dear students. I'm Dr. Mushfig Orujov, Associate Professor of Department of Pathological Anatomy of Azerbaijan Medical University. Today, our second lecture. The topic of today's lecture is mesenchymal degenerations, or in other words, extracellular or stromal-vascular degenerations. And second part of our lecture will discuss about the mixed degenerations. I hope you remember the definition of the degenerations that we discussed in our previous lecture, and we detailedly discussed about the intracellular or parenchymatous degenerations. Today, we have to discussing the extracellular degenerations. Extracellular degenerations also classified into three groups. The extracellular proteinaceous degenerations or dysproteinosis, extracellular fatty degenerations, dyslipidosis, and extracellular carbohydrate degenerations. If you remember from the histology course, the elements of the connective tissue during the microscopy, we use the different staining methods. For example, for the obtaining the collagen fibers, we use some different histochemical methods, as well as the Van Gison stains or Miller stains. Why we use these stains? Because usually in the pathology labs, we use the routine hematoxylin eosin stain. But during the hematoxylin or eosin or the H and E staining, it is very difficult to identify the connective tissue elements, especially the collagen, the fibrotic tissue. So we use the some different another methods. And during the using the Van Gison, this is very useful staining method for the collagen fibers. The collagen fiber stains in red brown, the cell nuclei to black, and other tissues to yellow. But in the Miller stain, the collagen also stain in the red brown. Elastic fibers. For the obtaining the elastic fibers, we have using the some methods. For example, the Virchow's Van Gison method and the Weger's resorption Fuchsin. For example, the Virchow's Van Gison methods, the elastic fibers and the nuclei, they stain the black, the collagen into red, and other tissues yellow. This is also the similar to the Van Gison methods, or the during the using the Weger's resorption Fuchsin, the elastic fibers they stain into blue, black, collagen into pink, red nuclei, the pale blue, black, and other structures the yellow. The Orsine staining method, elastic fibers they obtain the dark brownish purple, the background light brownish purple. And the Miller stain, we use the phosphotungstic acid hematoxylin. The elastic fibers they became to purplish. Also, you know, there are the reticular fibers in the connective tissue, and the reticular fibers stains with the reticordon and Swiss method. This is the silver impregnation technique that the reticular fibers obtain the black color and the nuclei are red. Here you see the Van Gison stain for obtaining the collagen fibers that here they stains into the red. This is similar, the Virchow's or the Van Gison stain modification, the cytoplasm yellow and the nuclei of the cells to the black or blue-black. Here we see we do the staining of the blood vessels by using the Virchow's 1 Guison staining. Here is the elastic artery, the wall of the aorta. When you use the Orsay stains, the elastic fibers or the elastic membranes become to the dark brownish purple color. Now let's discuss firstly about the extracellular pernicious degenerations or the dysproteinosis. There are 4 stages of the extracellular pernicious degenerations. First, mucoid degeneration or mucoid swelling. Second is fibronoid degenerations or fibronoid swelling. Third, hyalinosis, and fourth, amyloidosis. The first 3 processes are the consecutive stage of systemic disorganization of connective tissue. They commonly are present in chronic hypertension, diabetes mellitus, rheumatic diseases, allergy, and etc. But the amyloidosis develops independently. The first stage of the extracellular pernicious degenerations is mucoid degeneration. It is the superficial and reversible disorganization of connective tissue. It results by increasing of permeability of vascular wall from different causes and leakage of blood plasma to the vascular wall and out them that we call the plasmarrhea. The fiber structures, as well as the collagen fibers, elastic fibers, and ground substance or amorphic substance become swollen, and the protein metabolism disturbs in the ground substance. Abundant glycosaminoglycans are accumulated here. In general, the collagen fibers are swelled. If the pathological agents or the stimuli stop the process, is reversible and the tissue returns to normal condition. Otherwise, the process passes to a following stage that we call the fibronoid swelling. Here you see the microscopy of the mucoid swelling. In this area, we see the swollen the collagen fibers that they stains in the red. Here is the section of the blood vessels, also another vascular structures. Here we see we do the metachromasia phenomenon. What is the metachromasia? Metachromasia is a characteristic change in the color of staining carried out in biological tissues, exhibited by certain dyes when they bind to particular substances present in these tissues called chromotropes. For example, the toluidine blue becomes dark blue, where the color range from blue-red dependent on the glycosaminoglycans content when bound to the cartilage. Other widely used metachromatic stains are the hematological Giemsa and Mesenchymal stains that also contains the chiazine dyes. The white cell nucleus stains purple, the basophils granules intense magenta, whilst the cytoplasm stains blue. The absence of color change in staining is named orthochromasia. In the slides, we see the metachromasia in mucoid swelling. And we discussed just about microscopic and grossly appearance about the metachromasia. Microscopically, there is the basophilic core on basic substances. The collagen fibers save the structure, but swollen and they go to fibers this structure. Grossly, the tissues or the organ is safe that this process is convertible. Second stage of the extracellular pernicious degenerations is fibronoid swelling. It is a reversible disorder of extracellular structures. The fibronoid is a complex substance, so named due its resemblance to a coagulated fibrin. Fibronoid consists of plasma proteins, the extracted collagen fibers, and ground substance elements. Sometimes in the fibrinoid swelling areas, we found the necrotic zones that we call the fibrinoid necrosis, especially in the rheumatic diseases. The fibrinoid swelling together with the fibrinoid necrosis we call as the fibrinoid chains. Usually, the fibrinoid necrosis initiates inflammatory reaction and formation of the granulomas. For example, in the next semester, we'll study with you the rheumatism or the rheumatic fever, and we will see that here develops the Ashov granulomas. This is the inflammatory granulomas. These slides illustrate the rheumatoid swelling of connective tissue during the rheumatic fever. The destructive collagen fibers are stained in red because they are embedded with plasma proteins. This is here they're using the stains, the azocarbon by height and height. If you will pay attention to other structures, another collagen fibers, here we see the saving the normal structures in compare with the destructed collagen fibers. Another microscopy of the fibrinoid necrosis in the chronic hypertension. If you will pay attention, the renal glomeruli will found in the wall of the arterioles and capillaries, the necrotic areas. This is the bluish, the reddish areas shows the necrosis in the wall of the arterioles and the capillaries. Third stage of the extracellular pernicious degenerations is hyalinosis. The synonym is hyaline degenerations. Hyaline is a complex fibrous pernicious substance that include the plasma proteins as well as the immunoglobulins, complements, and lipids. This is the glassy translucent material. There are two types of the hyalinosis. First one, the vascular hyalinosis. They also maybe the local and the general. It present in the hyaline atherosclerosis in chronic hypertension, diabetes mellitus, and allergic diseases, and hyalinosis of the connective tissue also that divided to the local and the general. The vascular hyalinosis takes blood vessels of microcirculatory bed. It can be absorbed in the chronic hypertension, rheumatic fever, diabetes mellitus, chronic infections, autoimmune diseases, etc. The cause of vascular permeability disorder and plasmalogia in chronic hypertension is a damage of intima under the constantly high arterial pressure, but in the diabetes mellitus, increasing number of glucose and other bowel substances, intoxication. In the vascular hyalinosis, the blood vessels with neurodelumin and thick, hard, glass-like walls microscopy in hematoxylin eosin, hemagenose, eosinophilic, or pink, the unstructural mass. And the blood supply provided by these blood vessels disrupted, that we call this ischemia. Those organs are gradually sclerotized and shrunk. The vascular lumen can be either completely closed, for example, in capillaries during the diabetes mellitus, or they can easily be destroyed because the hyaline is loose and the vessels lose elasticity. For example, in the hemorrhage in the brain tissue in chronic hypertension, we call the hemorrhagic stroke. Here, as you see, the microscopy taken from the brain tissue, and here we see the section of the cerebral arteriole. As we pay attention, the wall of this arteriole very thickened, and that they feel the pink material. This is the vascular hyalinosis, and the lumen of this arteriole very narrow. During the hyalinosis, the splenic arterioles also they show the accumulation of the hyaline substances in their walls. Under the high power, we see the hyalinosis in the wall of the splenic arterioles, and also in the kidney, in the chronic hypertension. The wall of the arterioles undergo the change and they filled with the hyaline. There are three chemical variants of vascular hyaline. First, simple hyaline. They consist of the proteins only, occurs in hypertension. Lipohyaline consists of proteins and lipids. They present in the diabetes mellitus. And the complex hyaline, the proteins with the immune complexes that present in the rheumatic fever, autoimmune diseases. But another types of the hyalinosis is connective tissue hyalinosis. Can be found in scars, the base of the chronic peptic ulcer, in tonsils, in chronic tonsillitis, in appendix, during the chronic appendicitis, in cusps of heart valves, in defective valvular heart diseases, liver and spleen capsules after purulent peritonitis, and etc. Now we have discussed extracellular pattern shows degenerations of amyloidosis. The amyloid abnormal protein substance which deposit among the cells in various tissues and organs that we call this amyloidosis. Microscopically, this is the eosinophilic amorphous deposits similar to hyaline, and they found with special staining. Historically, the famous German pathologist Orujov, he found this material. He offered this is amyloid because these substances in the organs they similar to the starch, and the tincture properties of the amyloid similar to the starch. Cutting organs is painted with iodine, red brown, and sulfuric acid, dark blue. The amyloid binds a wide variety of proteoglycans and the glycosaminoglycans, and the presence of abundant charged sugar groups give the deposit staining characteristic that were thought to resemble starch. Pathogenesis of amyloid depositions. The amyloidosis is a disorder of protein misfolding, abnormal folding of normal or mutant proteins. Amyloid is not a structurally homogeneous protein, although it always has the same morphologic appearance. More than 20 different proteins can aggregate and form fibers with the appearance of amyloid. All amyloid deposits are composed of non-branching fibers, 7.5 to 10 nanometer in diameter, each formed of beta sheet polypeptide chains that are wound together. Main types of amyloid proteins. Amyloid light chains we call the AL, derived from the light chains, for example, the Benz-Jones protein in the myeloma diseases. The amyloid-associated protein, AA protein, derived from serum-associated amyloid, an acute phase reactant. Beta amyloid, derived from amyloid precursor protein, protein product of the chromosome 21, and endocrine amyloid. The deposition of these proteins may result from, first, excessive production of proteins that are prone to misfolding and aggregation. Second, mutations that produce proteins that can't fold properly and tend to aggregate, and defective or incomplete proteolytic degradation of extracellular proteins. Types of amyloidosis. Amyloidosis is a condition associated with a number of inherited and inflammatory disorders in which extracellular deposits of fibroproteins are responsible for tissue damage, and functional compromise. There are two types of the amyloidosis: general or generalized, systemic, and local. The general systemic amyloidosis also have some subtypes that we divided to the primary amyloidosis, for example, the AL amyloid disposition associated with multiple myelomas, secondary or reactive amyloidosis, AA amyloid associated with chronic inflammation in the rheumatic arthritis, tuberculosis, and hereditary amyloidosis, that autosomal recessive disorder involving AA amyloid, for example, the familial Mediterranean fever, and local amyloidosis that confined to a single organ, for example, brain. The generalized systemic amyloidosis, as we said, this is the primary amyloidosis, that AL amyloid disposition associated with immunocyte dyscrasias, multiple myeloma in 30% of cases, some B-cell lymphomas, secondary or reactive amyloidosis. Here, chemically, this is the AA amyloid that associated with chronic inflammation, the similar tissue involvement of both primary and secondary types in the liver, heart, gastrointestinal tract, and hereditary amyloidosis that they found in the familial Mediterranean fever in individuals the Sephardic Jews and Arabic origins, a febrile disorder characterized by attacks of fever accompanied by inflammation of serosal surfaces, including peritoneum, pleura, and synovial membrane. But local amyloidosis is present in different forms. For example, as the amyloid nodules. Here is the biochemical AL protein and nodular deposits of amyloid with the plasma cells they found in the lungs, the skin, tongue. The Alzheimer's diseases. Here is the alpha beta amyloid, endocrine amyloid, the certain the endocrine tumors such as the medullary carcinoma of the thyroid gland, islet tumors of the pancreas, pheochromocytomas, and undifferentiated carcinomas of the stomach. And also in the islets of the Langerhans, the diabetes mellitus type 2 is found. Also, the one type of the local amyloidosis is the amyloid of aging. The senile systemic amyloidosis in elderly patients, usually in their 70s and 80s, and with the dominant involvement and related dysfunction of the heart. Also one type of the senile cerebral amyloidosis. The morphology of the amyloid deposition. Histologically, the amyloid deposition is always extracellular. It begins between cells, often closely adjacent to basement membrane. Where can we find these amyloid depositions? In the blood vessels walls at first, in the kidney, spleen, liver, heart. Amyloidosis of the kidney. Grossly, they may appear unchanged, or here we see the pale areas, maybe abnormally large, gray, and firm. But in long standing cases, the kidney may be reduced in size that we call it as the amyloidogenic shrunken kidney. Here we do the microscopically structure of the renal or the kidney amyloidosis. In the glomeruli, the diffuse or nodular thickenings of the basement membranes of the capillary lobes we found, and the total obliteration of the vascular tuft. In the interstitial peritubular tissue, the frequently associated with the appearance of the amorphous pink cast within the tubular lumen, here you see, and in the walls of the blood vessels of all sizes, often causing the marker vascular neuron. And here we see also again the glomerular deposits in the renal glomerula, the deposit in interstitial blood vessels, and the amyloid cast the lumen of the convoluted or renal tubes. Also, another microscopy of the renal amyloidosis or the kidney amyloidosis by using the hematoxylin eosin methods. Here we see the amyloid deposition and using the methylene light. Here, finally, we can find the deposition of the amyloid in the renal glomeruli and the wall of the blood vessels. Amyloidosis of the spleen, the grossly often causes moderate or even marked enlargement, 200 to 800 gram, firm in consistency, and scar surfaces reveals pale gray waxy deposits. Microscopically, two patterns of amyloid deposits are found in the splenic folliculi, the producing tapioca-like granules. On gross examination in the interstitial peritubular tissue, we call the sago-spleen, and in the splenic sinuses and splenic pulp that forming large sheet-like deposits that we call the Lardashaw's spleen. Also, another microscopy of the amyloidosis of the spleen with the hematoxylin, eosin, and the methylene light stain. The liver amyloidosis. Grossly, the liver may cause a massive enlargement as much as 1 kilogram. The liver is extremely pale, grayish, and waxy. Microscopically, amyloid deposits are found in the space of this cell. They encroach of the adjacent hepatic parenchyma and sinusoids. The trapped liver cells undergo compression atrophy and are eventually replaced by sheets of amyloid. Normal liver function may be preserved even in the setting of severe involvement. The amyloidosis of the heart or cardiac amyloidosis. Grossly, the deposits may not be evident on gross examination, or they may cause minimal to moderate cardiac enlargement. There are gray-pink, dewdrop-like subendocardial elevations, particularly evident in the atrial chambers. Microscopically, amyloid deposits are found throughout the myocardium, between the myocardial fibers, and eventually causing their pressure atrophy. Amyloidosis of the other organs, the adrenals, thyroid, and the pituitary gland. The amyloid deposition begins in relation to stromal and endothelial cells and progressively encroaches on the parenchymal cells. In the gastrointestinal tract, amyloid may be found at all levels, sometimes producing tumorous masses that must be distinguished from neoplasms. Nodular depositions in the tongue may produce macroglossia. On the basis of the frequent involvement of the gastrointestinal tract in systemic cases, gingival, intestinal, and rectal biopsies serve in diagnosis of suspected cases. In patients receiving long-term dialysis, deposition of beta-2 microglobulin amyloid occurs most commonly in the carpal ligaments of the wrist, resulting in compression of the median nerve, the carpal tunnel syndrome. Common types of amyloidosis and associated clinical findings. The types we discussed that mainly they present as the primary and the secondary, and the clinical findings. In the renal amyloidosis, the nephrotic syndrome and renal failure, that common cause of death. In the amyloidosis of the heart, the arrhythmias, heart failure from the gastrointestinal tract, the macroglossia, malabsorption, hepatosplenomegaly, and carpal tunnel syndrome. It was the summary of our previous slides. Let me show you some slides. The grossly appearance of the thyroid glands during the amyloidosis, the amyloid myocardium stains by Lugol solution. You see here the affected area, they became to dark black after the action of the Lugol solution or the iodine solution. And we use the different techniques for detection of the amyloidosis, for the diagnosis of the amyloidosis, the immunoelectrophoresis to detect the light chains in primary amyloidosis, and tissue biopsy, especially the adipose tissue from the rectum, that subsequent Congo red staining, the most important tool in the diagnosis of amyloidosis. Let we classify these methods to the microscopically to the anti-microscopically. Microscopically, as we mentioned, we use the Lugol solution that stain the affected area of the amyloid area to the blue violet, and return a person's sulfate acid that stain to the dust green. The microscopically, as we can use some staining in the routine hematoxylin eosin staining. The eosinophilic, the amyloid areas, they color the pink and the hyaline-like amorphous substances. Usually we use the Congo red staining that stain to brick red. Also, we can use the Jensen violet that stain to the into the blue. Thiaflavin is specific brightness in luminescent microscopy, and in the polarized microscopy we found the greenish color. Here we see the biopsy taken from the lymph nodes, and normally in the lymph nodes absent the such depositions, and the Congo stains help us to detect the amyloid depositions here. Also the glomerular amyloidosis or the kidney amyloidosis. Here we use the thiaflavin T stain, and by the luminescent microscopy easily we can find the amyloid depositions here. Or the polarized microscopy after the Congo red stain. This greenish, the goldish structures, they show the accumulation of the deposition of the amyloid. The clinical classification of the amyloidosis. There are 10 types of the amyloidosis, the clinical forms of amyloidosis: cardiopathic, nephropathic, neuropathic, epineuropathic or adrenal, hepatopathic, dermopathic, enteropathic, splenopathic, mixed, and acute system amyloidosis. Now let we discuss about the extracellular mesenchymal fatty or fat degenerations. The mesenchymal fat degenerations occurred in metabolic disturbance of neutral fats or cholesterol, or it is ethers during the atherosclerosis. Neutral fat metabolism disturbances is characterized of increasing containment of fat in the fat depot. There are two variants of these degenerations: the general or generalized, that we call the obesity, and local, or the lipomatosis. Classification of the obesity. According to etiology, there are primary and the secondary obesity. The types of the secondary obesity are following. First, the alimentary obesity, incorrect nutrition and hypodynamia cases. Another one, cerebral obesity, cerebral tumors, cerebral traumas. Then endocrine obesity in some endocrine lesions such as the Cushing diseases, and hereditary obesity in some genetic diseases, that Lawrence diseases, Kirke diseases, and etc. Another classification according to the localization, topography of the fatty tissue. We can classify the upper type, middle type, lower type, and symmetric, but the most common type. For example, the upper type, the fatty tissue mostly accumulated in the upper region of the body. Degrees of the obesity. There are 4 degrees: first, third, second, third, and fourth degree. Here you see another illustration of regarding the degrees of the obesity, and here we use the body mass index. If the body mass index between 18.5 to 24.9, we take these persons as optimal. BMI between 25 to 29.9, overweight. BMI if between 30 to 34.9, this person is obese. Body mass index is if this more than 35, we call these patients as the morbidly obese, and more than 50 BMI, we call the super obese. According to morphology, the obesity has 2 variants: the hypertrophic variant and the hyperplastic variant. During the hypertrophic variant, the number of the adipocytes remain the same, but the cell volume of each adipocyte is growing, and a large amount of neuttral fats present in cytoplasm. The course of this variant is worse, but hyperplastic variant. In the hyperplastic variant, the number of the adipocytes is increasing, but the functions does not change. The metabolism doesn't disorder. The course of this variant is benign. And here, in this illustration, you see the comparison of the hyperplasia with the hypertrophy. Local mesenchymal fat disturbances that we call the lipomatosis. The samples of Dercum's disease. Dercum's disease is an extremely rare disorder characterized by multiple painful broad consisting of fatty tissue. We call this lipomas. These growths mainly occur on the trunk, the upper arms, and the upper legs, and are found just below the skin. The pain associated with Dercum disease can often be severe. Pain may be caused by this growth presence of nearby neurosis. The Dercum's disease mainly occurs in adults, and more women are affected than men. In some cases, affected individuals may also experience weight gain, depression, lethargy, and or confusion. The exact cause of Dercum disease is unknown. Diagnosis of Dercum disease is suspected based on a detailed patient history, a thorough clinical evaluation, and identification of characteristic multiple fatty growth. Surgical removal and microscopic biopsy of affected tissue confirms that this growth are lipomas. And here you see the lipomatous nodus during the Dercum diseases in the upper trunk, in the extremities. Microscopically, in obesity, the fat accumulated not only depot, it can be found in places where it never occurs in healthy condition. For example, in myocardium, under pericardium. Here you see the fatty degenerations of the myocardium. When we use the hematoxylin eosin staining, the fatty cells, they lost their fat and became to the ring cells. This is the empty structures. Empty cells are the fatty cells. Extracellular carbohydrate degenerations. are associated with glycoprotease and glycosaminoglycans metabolism disturbances and realized in tissues mucoidization. Connective tissue, stroma of organ, fatty tissue, cartilage become swollen, semi-transparent, have mucus-like appearance. The metabolic disturbances of mucopolysaccharides is usually developed as hereditary diseases and are called as mucopolysaccharidosis. Hurler syndrome, also known as mucopolysaccharidosis type 1, Hurler's disease, also gargoylism, is a genetic disorder that results in the buildup of glycosaminoglycans, that formerly known as mucopolysaccharides, due to a deficiency of alpha-L iodinase, an enzyme responsible for the degradation of mucopolysaccharides in lysosomes. Without this enzyme, a buildup of heparan sulfate and dermatan sulfate occur in the body. Symptoms appear during childhood and early days can occur due to the organ damage. Hurler syndrome is often classified as a lysosomal storage disease and is clinically related to Hunter syndrome. Hunter syndrome is X-linked while Hurler syndrome is autosomal recessive. It is named for Gertrude Hurler, a German pediatrician. Here you see the gross view of the patients with the gargoylism or the Hurler diseases. We finished our first part of the lecture. Now let's continue with the second part of the lecture about the mixed degenerations. Mixed degenerations, this is the morphological change or accumulation occur inside and outside cells of the proteins and the complex proteins and the mineral substances, minerals. So the mixed degenerations includes the chromoprotease metabolism disturbances, lipoprotease metabolism disturbances, nucleoprotease metabolism disturbances, and mineral metabolism disturbances. The chromoproteins, they are the colored proteins or pigments. They can be hemoglobinogenic, lipidogenic, and proteinogenic. The pigments that arrives from the hemoglobinogen, we can divide into two parts, the normal and abnormal, or the pathological. The normal pigments, you know, from the biochemistry course, also the hemosiderin, ferritin, and bilirubin. But the pathological or abnormal pigments are the porphyrin, hematoidin, and hematins. Let's now discuss about the normal pigments, hemoglobinogenic pigments, hemosiderin. This is the iron positive, brownish rusty pigment, chemically known as a polymer of ferritin. The cells that synthesize hemosiderin we call as sideroblasts, but macrophages ingest the hemosiderin, siderophage. We use the Prussian blue staining for the detection of the sideroblasts. They are the large cells with the large nucleus, that thin cytoplasm, and a lot of siderosomes that contain the hemosiderin. And the hemosiderin grains consist of ferritin molecules. A Prussian blue reaction is seen in this iron stain of the liver to demonstrate a large amount of the hemosiderin that are present within the cytoplasm of the hepatocytes and the Kupffer cells. Another illustration, the biopsy taken from the kidney, and these renal tubules contain large amounts of hemosiderin after the staining by the Prussian blue iron stain. Here you see the accumulation of the hemosiderin in this slide. Another biopsy taken from the lung, the brown coarse granular material in macrophage. This is in the alveolus is hemosiderin. Hemosiderosis. the results of increasing synthesis of hemosiderin with this accumulation in organs and tissues. Hemosiderosis can be hereditary, we call this thesaurismosis, and acquired, local or general. Acquired general hemosiderosis, mainly they present by the intravascular erythrocytes hemolysis during the blood diseases, poisoning by hemolytic poisons such as the snake's venom, during the severe infections such as malaria and incompatible blood transfusions. May be found in the liver, spleen, the lymph nodes, bone marrow. And the organs grossly enlarged and brown. Acquired local hemosiderosis. They develop during the hemolysis of the red blood cells extravascularly, during the hemorrhage, diapetes of the red blood cells during the venous congestions. Everywhere of the body we can find this damage. Classic example, the pulmonary or the lung hemosiderosis in chronic venous congestions that we call it the brown induration of lung. Now let we discuss about the bilirubin metabolism disturbance, or the bilirubin, as we say. The bilirubin is iron-free pigment, which is the end product of heme degradation. The heme is oxidized to the biliverdin, which is then reduced to bilirubin, free bilirubin. The bilirubin formed in mononuclear phagocyte system is released and bound to serum albumin. Then it is taken up by the liver cells, conjugate with 1 or 2 molecules of glucuronic acid that we call is the conjugated bilirubin. The conjugated bilirubin is secreted into the bile canaliculi. Intestinal bacteria, they conjugate the bilirubin and degrade it to urobilinogens, and the residue of intact pigments are excreted in the feces. The remaining 15% is glucurinated and absorbed in the intestine, returned to the liver, and promptly re-excreted into bile. Conjugated and unconjugated bile acids are also reabsorbed in the ileum and returned to the liver by intrahepatic circulation. The increasing of bilirubin containment in blood tissues are called the jaundice. The manifestation of the jaundice, the hyperbilirubinemia, yellow color of skin, scleras, visible mucous membrane. Only in obstructive jaundice there is intoxication due to chloralemia. In these cases, the bile present in blood. There are 3 types of the jaundice: the prehepatic or hemolytic, hepatic, parenchymatose, and post-hepatic or obstructive. During the prehepatic jaundice, they result by the hemolysis of the red blood cells inside of the blood vessels, the intravascular. Second type, the hepatic parenchymatose, during the injury of the hepatocytes. It may be during the hepatosis, the hepatitis, liver cirrhosis, and post-hepatic obstructive jaundice that develops during the blockade or difficulties of bile outflow, cholelithiasis, tumors of the pancreas or bile ducts, the destructive disease of the bile ducts, congenital defects of their structure, malignant tumor metastasis into hepatic lymph nodes. Here you see the illustration, schematic illustration of the prehepatic jaundice, hemolytic jaundice, that the red blood cells, they undergo the hemolysis intravascularly. Then intrahepatic jaundice, according the damage of the liver cells, and the post-hepatic jaundice, mainly the obstructive jaundice. Here we see the microscopy, the liver biopsy, and the yellow-green globular material seen in small bile ductus in the liver. This is the bilirubin pigment. And this condition we call this hepatic cholestasis. This bluish substances bilirubin. Not bluish, the yellow-green substances is bilirubin. Now we have discussion about the pathological hemoglobinogenic pigments. The porphyrin containment disturbances called the porphyria. These are rare hereditary diseases in which there is abnormal metabolism of the blood pigment hemoglobin. Porphyrins are excreted in the urine, which becomes dark. Other symptoms include mental disturbances and extreme sensitivity to the skin to light, The hypersensitivity to sunlight realizes as necrosis of skin and other membranes that we call the moonlight child. The types of the porphyria that affect the nervous system, also known as acute porphyria. Symptoms of acute porphyria include abdominal pain, chest pain, vomiting, infusion, constipation, fever, and seizures. These symptoms typically come and go with attacks that last 4 days to a week. Attacks may be triggered by alcohol, smoking, stress, or certain medications. If the skin is affected, blisters or itching may occur with sunlight exposure. And here you see the patients with the acute porphyria. The skin of these patients very hypersensitivity, and here develops the ulcers under the action of the sunlight. Hematoidin, the form of the hemosiderin, which is synthesizing in hypoxia, usually is absorbed in all hemorrhagic zones. Hematins, group of pathological hemoglobinogenic pigments occurring in different specific pathological situations. The hematomelanin, this is the malaria pigment. Hydrochloric acid hematin, these peptic ulcers that we found this pigment in the peptic ulcers, and the formaldehyde or the formalin pigments. The hemomelanin, another name we call as the hemozoin. And here, this section, you see the accumulation of this pigment in the liver cells. The formalin pigment in kidney section. When we long time they preserve the tissues in the formaldehyde, formalin, they appears here the presence, the accumulation of the pigment, the formaldehyde pigment. Lipidogenic pigments, they are include the lipofuscin, ceroid, pigment of vitamin E insufficiency, and the lipochromine. The lipofuscinosis, when the number of the lipofuscin increases in the tissues, we call the lipofuscinosis. They may be primary and the secondary. The primary, as rule, the hereditary, and the secondary develops during the cachexias, in some vitamin deficiency, chronic intoxications by hydrocarbons, the overindulgence in analgesics, especially metamizole. Most perfect examples are bone atrophy of liver and myocardium, often in elderly persons. The organs are decreased in size and bone. At the histological examination, yellowish or light brown small grains of lipofuscin there in cellular cytoplasm are observed. Lipofuscin in cardiac muscle cells. In this biopsy, we see with you And this is the goldish substances that accumulated in the cardiac muscle cells. Lipofuscin in liver cells. This arrow shows the accumulation of the lipofuscins in the hepatocytes, the insides of the hepatocytes. The proteinogenic pigments include the melanin, adrenochromine, and pigments of the acute system cell grains. Melanin, this is a famous protein, you know, that they synthesize by the melanoblasts, especially in the skin, in the hairs, in the nervous system. And disturbance of the melanin containment we call as the melanosis. The melanosis can be hypermelanosis and hypomelanosis. Also the hereditary and acquired, and the local and general. The general acquired hypermelanosis we can find in the Addison diseases, in bilateral destruction of adrenal glands, hypogonadism, the pellagra scurvi, and the cachexia. But the general hereditary hypermelanosis in the pigment xerodermia. Here we see we do the patients with the general acquired hypermelanosis. This is the Addison diseases, and in the gums of these patients we see the accumulation of the melanin, or the xerodermia pigmentosa, the structure, the accumulation of the melanin. Xerodermia pigmentosa, this is the general hereditary hypermelanosis. Local acquired hypermelanosis, the melanosis of the large intestines in earlier purple, suffering from chronic constipation, and black acanthosis, the skin areas with increased pigmentation in hypophyseal adenoma, hyperthyroidism, and diabetes mellitus. Increased local formation of melanin is observed in nevus, which may turn in malignant tumors, the melanomas. Here we see the endoscopic appearance of the melanosis of the large intestines, or the melanosis coli, that after the biopsy in the lamina propria of the large intestines, we found the accumulation of the melanin pigment. This is the structure of the large intestines after the surgery. And the congenital nevus, the mole or the birthmark, and here we see. And hypomelanosis can be divided to the general and local. General hypomelanosis, it is the congenital hypomelanosis known as the albinism. The term albinism typically refers to oculocutaneous albinism, a group of inherited disorders where there is little or no production of the pigment melanin. Signs of albinism are usually apparent in a person's skin, hair, and eye color, but sometimes differences are slight. People with albinism are also sensitive to the effects of the sun, so they are at increased risk of developing skin cancer. Leukoderma is the local acquired hypomelanosis that occurs after some inflammatory and necrotic processes in diabetes mellitus and in some cases, and remains as an area of depigmentation of the skin that here you see in the patients. Vitiligo is also local acquired hypomelanosis. The vitiligo partial or complete loss of pigment producing melanocytes within the epidermis. The epidemiology affects 1% of world population, more noticeable in dark-skinned individuals, usually hands, wrist, axilla, perioral, periorbital, and anogenital skin areas affected. Which sites affected? There may be focally only a few areas, segmented, one side of the body only, generalized, most common, both sides of the body, and trichrome. Patients has 3 shades of skin color. Clinical features of the vitiligo. maybe asymptomatic, flat, well-demarcated zones of the pigment loss, autoimmune disorders associated with pernicious anemia, Addison disease, Hashimoto's thyroiditis, perilesional skin up to 5 cm from vitiligo spot is still lighter than normal, associated with polymorphism in COX2 gene, mutations of autoimmune regulator gene may cause severe physiological distress, may worsen with local trauma, and vitiligo. Here we see the patients that with the signs of the vitiligo in the hands, in the trunk. Adrenochrome is an adrenaline oxidation product. It occurs in the form of granules in cells of medullary substance of adrenal glands. And here you see. Pigment of enterochromaffin cell granules occurs in cells of diffuse endocrine system. Enterochromaffin cells of stomach, bowels, B and C cells of thyroid gland, cells of juxtaglomerular apparatus of kidney, cells of Langerhans islands of pancreas. It is considered to be a serotonin analog. Carcinoids of tumors made of above-mentioned cells possess a significant serotonin activity. In such cases, patients get carcinoid syndrome. Now let me discuss about the nucleoprotease metabolism disturbances. First, urolithiasis, then uric acid infection of kidneys in newborn, and gout. Gout, from the Greek podagra, the podos, food, agra meaning the tract. This is the chronic disease, is characterized by sedimentation of uric acid salts or urease in organs and tissues, and accompanied with hyperuricemia and hyperuricuria. Most often, urease is accumulated in skin, joint, kidneys, blood vessels. Necrosis, chronic inflammation, sclerosis, results of urease sedimentation in a tissue, and irreversible deformation of joints found in these diseases, and chronic renal failure develops in these patients that we call the gout kidney or tubulopathia. Here you see the patients with food with the gout. Now the final chapter of our lecture is mineral metabolism disturbances. First, let me discuss about the calcium metabolism disturbances. The pathological classification is the sedimentation of the calcium salts into organs and tissues. Pathological classification can be according to the location, intracellular, extracellular, and mixed, according to propagation or the localization, the systemic and local, and according to the mechanism of its development, metastatic, metabolic, and degenerative. Metastatic classification as well is general, widespread, always there is hypercalcemia. It is possible in thyroid gland adenomas, parathyroid glands adenomas, massive destruction of calcium deposits in bones, increased vitamin D containment, kidney diseases, gastrointestinal tract diseases. Usually, calcium salts in metastatic classification deposit in gastrointestinal tract mucosa, lungs, skin, blood vessels, myocardium, and kidneys. Metabolic classification, the causes are unknown, results of acid-base condition disorder in a tissue, and can be local and generalized. And degenerative classification or petrification is always local. There is no hypercalcemia, calcium, and the calcium salts deposit in necrotic foci or zones of tissues with sharply decreased vital functions. The examples of petrifications, the petrification in thrombi, in atherosclerotic plaques, in tumor stroma, in cusps, in defective valvular heart diseases, the petrification of purulent exudate in chronic purulent inflammation, petrification of caseous necrosis in tuberculosis, petrification in syphilitic mass, petrification in place of dead parasites, for example, the echinococci and the petrification in place of dead fetus. We call the lithopedion. Stone formation. The stone is pathological hard formation freely lying in a duct or an organ's cavity. The predisposing factors of stone formation, the disturbance of general metabolism and local, the chronic inflammation, slowing of outflow, change of secretion, chemical composition, and its physics features. Every stone has inorganic matrix and organic part. The complication of stone formation, the difficulties or total blockade of outflow, supporting of chronic inflammation, and necrosis, fistula, and bed sore in tissue under stone. Here you see the microscopy taken from the lung tissue, and here this patient have a very high serum calcium level, hypercalcemia, and here you see the accumulation of the calcium salts in the alveoli, and the degenerative cardiac calcinosis. You see here calcium salts, the disturbance of copper metabolism. Mainly they found in the Wilson disease. The Wilson disease is a genetic disorder in which copper builds up in the body. Symptoms are typically related to the brain and liver. The liver-related symptoms include vomiting, weakness, the fluid build up in the abdomen, swelling of the legs, yellowish skin, and itchings. Brain-related symptoms include tremors, muscle stiffness, trouble speaking, personality change, anxiety, and seeing or hearing things that others do not. Wilson disease is an autosomal recessive condition due to a mutation in the Wilson disease protein gene. For a person to be affected, they must inherit an affected copy of the gene from each parent. Diagnosis may be difficult and often involves a combination of blood tests, urine tests, and liver biopsy. Genetic testing may be used to screen family members of those affected. Wilson disease is typically treated with dietary change. Complication of Wilson disease can include the liver failure, liver cancer, and the kidney problems. A liver transplant may be helpful in those in whom other treatments are not effective or if liver failure occurs. The Wilson disease occurs in about 1 in 30,000 people. Symptoms usually begin between the age of 5 and 35, and males and females are equally affected. It was first described by Frederick Theodor von Friedrich and is named after Samuel Wilson in 1854. And here you see the pathophysiology and the histopathology of the Wilson disease and the formation of the Kaiser-Fleischer ring in the eye and the copper stain during the Wilson diseases. And there you see the accumulation of the copper. And stone disorders. Kidney stone disease is known also as the urolithiasis or nephrolithiasis. The kidney stone disease is when a solid piece of material, kidney stone, occurs in the urinary tract. The kidney stones typically form in the kidney and leave the body in the urine stream. A small stone may pass without causing symptoms. If a stone grows to more than 5 millimeters, it can cause blockage of the ureter, resulting in severe pain in the lower back or abdomen. A stone may also result in blood in the urine, vomiting, or painful urination. About half of people will have another stone within 10 years. In the kidney stone diseases, most stones form due to a combination of genetics and environmental factors. Risk factors include high urine calcium levels, obesity, certain foods, some medications, calcium supplements, hyperparathyroidism, gout, and not drinking enough fluids. Stones form in the kidney when minerals in urine are at high concentration. The diagnosis is usually based on symptoms, urine testing, and medical imaging. Blood tests may also be useful. The stones are typically classified by their location: nephrolithiasis in the kidney, ureterolithiasis in the ureter, cystolithiasis in the urinary bladder, or by what they are made of: the calcium, uric acid, steroid, and cysteine. And here you see the illustration, the gross view of the urolithiasis, the kidney stone, the urinary bladder stones, then stones from the kidney pelvis, and the stones in gallbladder during the cholelithiasis. So now we finished our lecture. Thank you for your attention.